Hello, everyone, and welcome to this AnaBios presentation. My name is Chris Mathis. I'm the Chief Commercial Officer of AnaBios, and it's my pleasure to be the moderator today for this webinar. Before I introduce our speaker, I'd like to tell you about AnaBios. I want to make sure everyone on the call knows who we are. We are a unique contract research organization and biotech company based in San Diego. AnaBios procures human tissue samples from ethically consented donors, and we do research with the tissue or cells to perform physiological assays in which we can test preclinical compounds for drug discovery projects. AnaBios has essentially redefined first in human. So it's my pleasure to introduce our speaker today. He is Dr. Patrick Doherty, who is the HEB professor in cancer research at the Department of Pain Medicine, Division of Anesthesiology and Critical Care at the University of Texas MD Anderson Cancer Center in Houston, Texas. Patrick is also an adjunct professor, Department of Neurobiology and Anatomy at the University of Texas Health Sciences Center in Houston. He did his PhD in biomedical science in 1988 from University of Texas Graduate School of Biomedical Science, and before that received a medical degree from the University of Texas Medical School. So at AnaBios, we've had the pleasure of collaborating with Dr. Doherty in the past, and I've enjoyed interacting with him at pain-related research conferences over the years. So without further ado, Patrick, thanks for being here, and over to you.
All right, absolutely. Thank you. And thank you for everyone that's in attendance. I guess initial slide, you can see a picture of the Texas Medical Center, and off to the left there, you can see downtown Houston. You don't want to confuse one city for the other city. And what I'm going to talk to you today about, you can see there on the title, what we've been very interested in my group is looking at potential roles for chemotherapy-related peripheral neuropathy. I work at the Cancer Center. This is obviously a big problem that we experience. And I'm going to talk about some potential treatment avenues that we've revealed, looking at this process where we've identified that spontaneous activity develops ectopically in the dorsal root ganglia, both of chemotherapy-treated animals, and I'll also show you data from humans. And I guess that's the take-home message here, why we're speaking in AnaBios. And essentially what we're doing is we're using human tissue. There we go, okay. We're using modeling processes in animals, and then jumping over and validating the processes that we see in animals using human tissues. That's essentially the gist of our work. I'll also just preface, this is going to be essentially the same talk that I gave back in May at the NUPSIG meeting in London. So if you're in attendance there, you're probably not going to hear much new. If you were that interested and you want to hear it again, then that's just great. But just to save people time, I don't want you to be disappointed if you listen to this and you think, I've heard it all before. Otherwise, if you weren't at the NUPSIG meeting, this may be an incentive to come in the future. There's some really excellent science there. It's a great meeting. In any case, this is the general premise that we're looking at, and then we'll move into the specifics. And so this slide here is published in Pain back in 2017. And what we've done is we've excised and then dissociated dorsal root ganglion neurons from animals that we've treated with Taxol. And those animals develop a hypersensitivity that seems to mimic then chemotherapy-induced peripheral neuropathy. So it's a model in rodents of chemotherapy-induced neuropathy. And the main point is up here in this left-hand corner, where if you take these ganglion neurons out of animals that have been treated with just vehicle, what you see is that the cells just sit in culture and basically just do nothing. Very, very rarely do we see any spontaneous activity at all, and if we do, it's diminishingly low. Contrast that then to ganglion neuron taken out of animals at 7 days after chemotherapy or even 2 weeks after chemotherapy, and you can see there's quite a bit of after discharge that you're observing. Again, you have the rates down here where you're looking at roughly 30–40% of cells at peak. And yet 2 weeks, this level tapers off to around 10%. But I can tell you that 10% of your nociceptors were still spontaneously discharging at 2 spikes per second or so, you would be in extreme agony. As well, you can see over here at the right that there's a second level of hyperactivity or hyperexcitability that develops in these cells, where the level of response to intracellular current injection becomes markedly elevated, and that's still sustained with no change, and Riobase is also markedly reduced. So these cells show then two kinds of hyperactivity, one where you have overt spontaneous activity, and the other where you have evoked related hyperactivity. Where that fits and why I'm emphasizing this is that we had published actually a number of years ago that when you look at spinal neurons from animals with any one of these chemotherapy-related neuropathies by any number of different drugs, what you find is this crazy hyperactivity that you get. So up here, you can see what would normally happen with spinal neurons. You put something on the skin and you take it off as indicated by these lines. And yeah, the spinal neurons discharge. If you squeeze the skin or something that's really painful, maybe get a couple of spikes, but basically the cells go quiet. You can obviously see the big difference that we're getting in these chemotherapy treated animals. We saw this exact same phenomenon, this crazy after discharge in spinal neurons, both in rodents and in primates, using the old-fashioned neuropathy model, so the CCI model of Gary Bennett or the spinal nerve ligation model developed by Jim Mo Chung. You see the exact same thing. So we're very interested then in how this hyperexcitability in the primary efferent neurons may then be driving this hyperexcitability that you see in spinal neurons. And anybody that's worked with any of these models will probably or can envision the behavior that you get where these animals will yank their foot away and then lick it and rub it and roll away and try to hide their paw from you, acting like they have really this exaggerated, ongoing, exacerbated pain response. So it seems to fit quite together. So this was really intriguing to us and got us very excited. And I want to zero in on the type of activity that we actually see. So Marshall DeVore actually a number of years ago and has been talking about this for years, that you get spontaneous activity developing in dorsal ganglion neurons. And he had reported this type that we also see in large diameter neurons. And you can see that the baseline shows you these oscillations, these regular oscillations in membrane potential that finally lead to a spike. What we're seeing in nociceptors is quite different, where you can see you get these irregular depolarizing spontaneous fluctuations in membrane potential that look quite chaotic as opposed to these much more rhythmic oscillations in membrane potential. And the sort of the striking thing about this then is that when we then carried forward and we had an opportunity to look in humans, we found not only the spontaneous activity, but I'll show you in another slide that you get these same spontaneous fluctuations in membrane potential as well. So here's really then where the animal models I found to be just beautifully validated. So we had then the internal cohesion in the animal models where that seemed to fit their behavior. But in humans, we had this opportunity at MD Anderson where we have a number of patients that present and they have these metastases into the vertebral bodies. And sometimes these then will extend out and compress the roots of the spinal cord, which here would be the spinal cord in this slide. And you can see that the roots being squashed. And in this case, a good chunk of the spinal cord is being squashed. And we either get patients then that have this axial pain that we think is just nociceptive from the tumor, not neuropathic because the spinal cord and the roots are intact, or you get this radiating pain crossed throughout the dermatome. Sometimes it's on one side of the spinal cord like this. Sometimes you get bilateral, but you have quite clear radicular pain in these patients. So they have a spinal cord compression. They have an ongoing neuropathic pain, and you can see the spontaneous activity that develops is quite robust. And you can again look and see what the number of DRGs and the incidence, and if the DRGs are taken out of a segment with no pain. So for example, in this patient, if we took this DRG from this side, or either of the DRGs taken from this patient, there's no nerve compression, there's no reported pain, there's no spontaneous activity. It simply just doesn't occur. Whereas with pain, you can see we get quite a robust rate of spontaneous activity. And again, you're starting to see some of the same things where spike threshold is going down. And I'll show you, I think in a bit, we have now data showing where if we inject current, we also get that same shift in the SR function. So this is just a raster plot to show you, again, if there's no pain, very infrequent occurrence. This was essentially one neuron where we saw some spontaneous activity in human DRG in a dermatome without pain, whereas in the dermatomes with pain, you can see that it's quite robust and is occurring in multiple numbers of neurons. This is just a blow up now to show you the isoelectric line, where again, if the neurons coming out of humans are silent, you can see that the membrane potential itself is also very tightly regulated. But looking at just a portion of the spontaneous activity from one of these spontaneously active neurons, you can again see these chaotic fluctuations of membrane potential. This slide here is just lining up the two, where we're looking at spontaneous activity occurring with nerve injury, either chemotherapy. Again, you can use whatever model of nerve injury you want, and we see the same thing. So we've seen this with surgical injury in experimental animals, with CCI in experimental animals. Terry Walters has reported it, good friend and collaborator of ours, has reported this in spinal cord injury, and now we're seeing the same process that appears in human neurons. So it looks like there's multiple pathways, but you end up with a very common denominator with this spontaneous activity, and just then trying to pick which is which. And you can see that the rat is here on the left and the human is over here on the right. So the process is then that you would get this spontaneous activity would include either a decrease in AP threshold, so that's a decrease in spike threshold itself, a depolarization of resting membrane potential, and of course then the difference between these two is the decreased rheobase that you see, and then these large DSFs, which you can see action potentials tend to ride right along the top of those. So these are the three processes that Max and Terry's group have shown very nicely in spinal cord injury as contributing to spontaneous activity, and we're seeing then the same thing that seems to be occurring in humans. So moving a bit forward, we've jumped back now to animal models, and we're starting now, we're going to focus on the role of various processes that we've previously seen in experimental animals that might contribute to this spontaneous activity that we see in humans. And the rest of this talk now, I'm going to move back and forth between some of the different mechanisms that we've outlined in experimental animals as contributing to the spontaneous activity, and then I'll show how we've come back then to that these spontaneously active neurons in humans to validate whether those might be potential therapeutic avenues worth following or not. So one of the first things that we saw, and this paper has been published now for a while, that as you treat animals with Taxol and they develop the hypersensitivity, what you see is that the dorsal ganglion becomes more and more infiltrated with CD68 positive macrophages. So here you can see a normal dorsal ganglion. There's a couple of macrophages in there, but over time, treating with Taxol, you can see it becomes more and more full, and then those start to taper away as you start getting into the resolution phase in the model. Looking in, and this is just a blow up of the same thing, where you're seeing then just a nice picture from experimental animals. There's a beautiful macrophage right there, very typical profile. Here's another one, and a number of others. The importance to the macrophages we sort of validated by going in and wiping them out. So again, here's the normal behavioral hypersensitivity that we would get as we treat animals with Taxol alone. But as we give this macrophage poison cladronate and kill off the macrophages, you can see that that suppresses then any further development of this hypersensitivity model. And these panels here are just showing you normal spleen before and after cladronate, DRG before and after cladronate, and then the number of macrophages in both places that are quantified. So the intended treatment is working quite well. Whoops, carrying over then to human, you can see a low power view of the whole human dorsal ganglion here. And in the green alone is CD68 staining, and then the yellow is where you're also getting this co-expression of LAMP1, which is a lysosome-associated protein. Again, just another marker of macrophage. You can see again the ganglion is becoming quite chock full of these ganglia, and this, I mean, of these macrophages, and this is to blow up of the same thing. We can see they're infiltrating, looking very much like the pattern that we saw in animals. So that suggests that ultimately an immune type therapy may be of benefit in addressing these chemotherapy-related issues and neuropathic pain issues in humans. We've done a number of studies, again, looking at changes of ion channels occurring in the ganglion. Two that we published, CAF 3.2, NAV 1.7, and you can see, again, just comparing the animal dorsal ganglion to the paclitaxel treated, you can see this marked up regulation. Here, what you're seeing now is a more recent paper, and each of these papers, by the way, I didn't put this data into this, but in the same papers, we have examples of human dorsal ganglion neurons as well as animal ganglion neurons that we show suppress this activity using a CAF 3.2 antagonist. And then we have human neurons as well, show the same thing where you get this upregulation in CAF 3.2 and you use a CAF 3.2 antagonist and it suppresses the spontaneous activity that we were able to record out of those human neurons. Same thing with NAV 1.7. I can just refer you to those papers that show that we've directly in each of these verified that either CAF 3.2 or NAV 1.7 look like they may be interesting treatment avenues for the suppression of spontaneous activity in human ganglion. This is a more recent paper published along with Ted Price's group, where again we're looking now in the top is in mice, and what we're looking at here is the occurrence of spontaneous activity across ganglia as we treat animals with Taxol. We can see the same shift in rheobase that we get, but here what we're using to suppress this activity, now again the same spontaneous activity is this compound EFT508, which is essentially a transcription inhibitor, a MINC inhibitor. So what it's telling us, and it was really interesting, so the previous slides we were showing that there's this ion channel upregulations that occur. This is showing in this slide, and the implication here is that not only is this spontaneous activity being driven by changes in ion channel expression, but this says that as well this activity is being driven by ongoing translation of some type of proteins that are supporting this activity. This is where we carried it over now, and we're showing the exact same results in human neurons. So again, one of these human neurons spontaneously active, we apply EFT508, you can see the activity goes away very nicely. And here you can see the quantification over, I don't remember how many neurons this is, this 6 or 8 neurons that we tested this in, and we had a uniform effect each time. The other interesting thing is that you can see that, in fact, you notice that there's this change in rheobase. So you can, even though each of the steps aren't demarcated, you can tell here this is only one step, and we got an action potential at 10 picoamps. Here we had to take several steps, and it took us up to 140 picoamps in order to drive the first spike when these cells are being suppressed. So not only are we changing then one of those parameters, the spontaneous activity, the oscillations I'm not blowing up on, but those are also suppressed. But here also you can then see that rheobase is being changed as well in these neurons with this translation inhibitory agent. There's I mentioned the immune process. So we know that you can suppress the development of the CIPN model using ablating out macrophages. This is a study that we did in collaboration with Annemieke Cavalier's group here at MD Anderson that shows that in this resolution phase, if you knock out T cells, you also will inhibit the resolution of the CIPN model. So here we have the development of the model. What did I do here? Got off my slides there. In each case, I've gotten off track here a little bit. So this is where we were, again, looking at the same model with Annemiek's group. We identified then that knocking out T cells it was an important resolution, and that process was dependent on the generation of the generation by infiltrating T cells, driving macrophages then into an M2 state to produce interleukin 10. This is from then those experimental animals where again we found the spontaneous activity. We applied interleukin 10. You can see that that knocks out that activity quite nicely. And then as you wash it out, it recovers back. So this IL-10 seems to be actually driving suppression of the spontaneous activity that's in the acute resolution phase. And again, you can see just the summary data is over here. This slide now is where we're trying the same thing, IL-10, but now in human neurons. A number of examples, and you can see again the spontaneous activity is going away. You can see the really chaotic fluctuations again. Here they're quite nicely suppressed in each one of the examples. There's still some chaos in there, but we know that if we take the IL-10, we wash it out, that activity is going to come right back. So the IL-10, at least in this acute phase, will directly suppress this activity, but we're not getting restoration. Presumably what we need is a sustained presence of this IL-10 in order to get everything to completely reset. So in this now, we're looking at a EPAC inhibitor. So this is Taxol plus the EPAC inhibitor ESI-09. And so this is just behavioral studies now showing that we can, in either case, treating with ESI-09 will suppress the behavioral phenotype here produced by spinal nerve injury. Again, you see this development of spontaneous activity that we get in either of these models. Applying ESI-09 will again suppress this spontaneous activity. Here's the quantification that you can see below. And this one as well, we've recently extended, and we know that the same EPAC inhibitor will work in human neurons also to suppress this. So we have then a number of targets that we can look at. AnaBios group has also looked at HDAC6 inhibitors. This gives a very nice behavioral phenotype. I can see now I got my slide switched. That's what threw me off prior. In any case, this one yet, I don't have any human data on, so this is one area that we could actively explore to see and validate still with human neurons. More recently, we've moved now, this is data from my lab where we've looked at and we've seen that the HCN inhibitors, either ivabradine or ZDC288, give a very nice suppression of the chemotherapy-induced neuropathy. The interesting thing that we did in this particular one, we can show an upregulation, but this panel here is let me go back. This panel here is where we did a nifty thing where, again, we were looking at spontaneous activity in these neurons that occurs again, same story. But what we did here was a single cell PCR looking for the expression of HCN2. And you can see that when the spontaneous activity was present, you had very nice upregulation of HCN2. And in cells where you didn't have spontaneous activity, you really had nothing. Very weak expression in this one particular cell, but it seemed that HCN2 in particular is very nicely upregulated. And this is down here an example from animal. I believe this one is still an animal cell, but we get the same exact result in looking at, again, testing this in human neurons. So we believe that HCN2 also is a very nice example. More recently, then, this is studies now where we've taken our same human cells, and we actually did whole cell genotyping in the same subject. So we had done physiology. We can separate them out by either men with pain or men without pain. And just looking in the cohorts, we find that you can get a very nice expression pattern where as you generate pain, you can see that there's a very nice upregulation in signaling that we can follow up on now as future potential targets. One particular one that I'm going to emphasize is alkostatin M. I'm pretty sure I have data related to this to show you. This looks like a very interesting compound. It's a pro-inflammatory interleukin 6 related ligand. Folks may know that interleukin 6 antibodies themselves did not work out very well clinically, but interleukin-6 receptor antagonists seem to have a nice phenotype. And one of the reasons that may be is that the interleukin-6 isn't an adequate block because other ligands to that site, like oncostatin M, can jump in and block on that. And so here we're now returning to animal studies where we show that we get a very nice upregulation. So this is normal over here, but as you treat with chemotherapy, you can see you get a very strong upregulation of oncostatin M. This is just showing another pattern of that, where the previous was in neurons. This looks more like in the surround around some of these neurons, or potentially from satellite cells. This is just the showing now the receptor, where you can again see that we're getting very nice upregulation of a lot of this receptor, and we find no co-localization of the receptor, interestingly, to TRPV1. It only seems to be in the IB4 positive cells. So just kind of a striking result that we've gotten there. And this is just the example of showing very nice co-localization with IB4 positive cells. And as well, you can see then in the white here that there's some co-localization to CGRP containing cells. This then is again back to animals, where we then took from humans. Now we're reverse translating. We gave oncostatin M to animals, and you can see it developed a very nice mechanical hypersensitivity. But interesting, in sort of course matching up to the previous anatomy, we don't see any change in withdrawal latency to heat. We're only getting a mechanical hypersensitivity. So just taking from the human, backing up to the animals, and looking to see how it lines up, and it's interesting that we got this. So here you then see where we're now, in this case, taking a naive animal dorsal ganglion neuron and applying oncostatin M. You can see it evokes this from a silent cell to now a wildly active cell. And again, you can see the fluctuations that oncostatin M tends to drive in these cells. Also, it's interesting that we get this very interesting burst pattern with oncostatin M. This is human, and we found the exact same thing in humans. You can see that you get this strong burst to the point where it looks like you get even a depolarization block. So this is one where then we've taken the study, back translated it then into animals, and then reversed and gone back then into humans to verify that oncostatin M does seem to be a potential way of driving spontaneous activity, but with an interesting, very specific signature to that activity that we tend to get. And then this slide now is I think one of the last ones that I want to get to, where here what we're looking at is the differences then where we have men pain and female pain. So when we first did the genotyping study, it was sort of an interesting experience for Ted's group and ours, in that when we initially did the analysis on the transcriptomic profiling, we weren't actually able to get any signal of when we had all of our pain cohort versus our non-pain cohort in one big pool. And we spent actually a good day and a half sorting through, trying to look at every clinical parameter we could to tease out a signal. Finally, we decided, well, let's just go ahead and separate the men and women. And lo and behold, that's where we then finally got a large signal. I showed you previously the men pain versus no pain. It's where we revealed the oncostatin M that I just showed you about. But this one here now is where we're separating out men versus women. You can see there's quite a different signature, where men are upregulating a lot of transcription factors more so than women are. Whereas down here, you see that the women are tending to upregulate a lot of G protein coupled type receptors. And so, and I think one that sticks out is this adenosine receptor here. And so it will suggest that as we move forward, it's going to be important to keep our eye on the potential of sex differences, both in the underlying mechanisms that would be potentially generating this spontaneous activity that I just spent all this time talking about, but then as well then would also predict changes in potential therapeutic targets. So this again then is just a summary of sort of everything that you saw. We still have the HDAC6 left to fully verify. The mink IF4, we have that data now. So there was a question when I first presented this. We now have data on that tied down in humans very nicely. And the interleukin 10 as well. I showed you the data that we've just got generated on that. We know that we have a new signaling here, this alkastatin M, that we've translated into animals. We know that that generates a pain phenotype. And then we've turned around, we can also show that in humans, this will provoke spontaneous activity all on its own in otherwise silent neurons. A lot of this work, of course, we built on a lot of this TLR4 signaling that we can connect then to the increased expression of cyclic AMP, and that leads then to the HCN2 and the EPAC story, potentially helping to drive the depolarization of these cells. And then sort of the triggering elements can be CAV32, NaV17. I haven't talked at all about NaV18, but in any case, that's yet another target. And so that's sort of the summary of where we've been, what we've sort of validated now with initial discovery in animals, then validation into humans, so that we now have what we think is the beginnings of an outline of a mechanistic signaling pathway. This last slide is important because this is all the people that did the work. So here at MD Anderson, Yan Lee and Megan Uelski are in my lab doing a lot of this work now. Our neurosurgical colleagues are Dr. Tatsui, Rao, and Rines, and then the two doctors, Zhang, they're not related, but they also contributed quite a bit. And of course, we have strong collaboration with Kobe Hein and Anamika Cavalar's group over at UT Health, which is just across the campus, Terry Walter's group, and Max was his postdoc, and Ryan postdoc that worked out a lot of the initial work on the DSF. And of course, at UT Dallas, we have Ted Price group. Pradipta is a up-and-coming young scientist who's big in the analysis of the transcriptomic data. And then, of course, we have to acknowledge the folks that actually pay the bills. And that's all I have to show you today.
Thank you very much, Patrick. Really appreciate the presentation. And just a reminder to everyone in the audience, if you have a question, you can type it into the chat box in the lower right-hand corner. If you just click on the arrow next to chat, and you can type your message in, and we'll read it. And in the meantime, I have a question for you, Patrick. You talked about the whole cell genotyping and the expression pattern. There was several different targets there. It seems a little bit daunting from a drug discovery perspective to go after so many targets, and one of your last slides showed that. And then on top of that, you have the sex differences. So, any advice to the people on the line that are doing drug discovery, looking for molecules that go after one target? How do you approach something like that, at least from your perspective?
Yeah, there's clearly a bunch of targets there. Right now, our focus is being driven less toward the ion channel inhibitors because I would expect that the side effect profile would be steeper there. What's much more intriguing to me is targeting those depolarizing fluctuations. And I think the idea that there's an ongoing transcriptomic process that's driving those fluctuations, to me, is extremely exciting because, again, since those are sub-threshold, my expectation would be that your side effect profile would be much reduced there. To sort of advance some of this entire work, we now have and just have working still to be optimized, but we're able to actually follow up the single cell patch with PCR with a little more sophisticated now, where we can take single cell patch and then follow that up with single cell transcriptomic profiling. So deep RNA-seq on a single cell. I call it patch-seq. And that will now let us actually identify the specific types of cells that develop this spontaneous activity. We can ask the question of whether those are the same cells across models. And then as well, once we identify the cells and we can get at the deeper profiling, that may actually get us more specific targeting and also guide then the data mining from the bulk sequencing on the DRG as a whole.
Okay, we have some questions over here on the right. When using human DRGs, do you observe a lot of patient-to-patient variability?
So our primary source is again, most of the ganglia that we get are coming straight from the operating room, and patients that need to have a surgical resection of tumors that have gotten into those vertebral bodies. The big difference that we see is whether and what the pain profiling in those patients are. If patients have radiculopathy, then that's when we tend to find spontaneous activity in the ganglia. If they don't have radiculopathy, they don't have a nerve compression, then they don't have that spontaneous activity. So that's the biggest difference that we see. Now, you get into the deeper weeds. Is there a specific correlation between the rate of spontaneous activity, say, and that patient and a given patient's pain rating? That's where we see more heterogeneity. So and I don't know if that's just a sampling issue at this point. We just need to continue to build our samples or not. The other heterogeneity came out in the transcriptomic data. And again, that was quite surprising that men and women are showing quite distinct patterns. And so it'll be interesting to see what we get as we do the single cell profiling as well.
Do you think that's one reason there haven't been a lot of effective non-opioid pain treatments, because the strategies have been to go after one target instead of perhaps multiple targets?
That's certainly the implication as well. I think you could go back and look at some of those clinical trials. Did you stratify by sex?
Yeah, right. You talked about immune therapy and killing the macrophages. Have those been tried clinically, and if so, are there side effects to those types of treatment?
No, wiping out macrophages is not going to be the route to go. The much more interesting approach is what came out of that work by Karen Krukowski and has been followed up on in Anamika's group, where it looks like you can condition T regulatory cells and potentially give those back to a patient. That I think would be a much more promising approach.
Here's a question related to that. Do you think the macrophage infiltration is necessary for the transcriptional changes seen, or could they be cell intrinsic in response to chemotherapeutics?
Now that's a really excellent question, and I actually have a paper. You can't see it because it's behind the slides that I'm working on right now, where we've been taking dorsal ganglion cells and treating them in culture with chemotherapeutic agents. What the goal of that project is to actually see if we can't get those cells to become spontaneously active. And we are able to get very close. We can get some hyperexcitability in those cells, but we haven't actually been able to get spontaneous activity. Those cultures are fundamentally limited because we don't have macrophages in them. So it seems that the macrophages will be very important in driving some elements. Others seem to be neuron specific. So that's the best answer I can tell you now. You get into the idea of, look how many things are released by macrophages that could definitely change the transcriptomic profile in neurons and their plethora. Right.
Another question from the audience: how does endorphin found in T cells interact with these observations?
We have not explored that. Interesting question. In our particular environment, endorphins and the entire opioid class is an interesting and tricky problem because of the interactions with tumor cells. So I don't know that we're going to chase after that, but that certainly leaves ground for other folks to explore.
Okay, maybe someone in the audience will pick that up. Another question from the audience: would you expect similar mechanisms in diabetic peripheral neuropathy?
So, so far, every model that we've looked at in experimental animals, we have found this spontaneous activity. So I would expect that, yes, if you have a model that generates spontaneous pain in the animal, I think it's being driven by the development of this spontaneous activity in the ganglia. Now, are there other generators? Very possibly. So distal endings, there's a number of investigators, Gary Bennett's group jumps to mind, has shown in his CCI model by example, Jim Mo-Chung as well, that distal endings also can support some spontaneous activity. We're interested in the ganglia because, again, every model that we've looked at, be it surgical injury, CCI, et cetera, we see spontaneous activity develop in these ganglia, and it shows the same general pattern in the isoelectric line. So again, we get that chaotic depolarizing fluctuations. Now, the difference being that in a surgical model, that activity fades away in a day or two. Other models, it's more persistent. Is there a single pathway to generate these DSFs? Probably not. There's probably multiple pathways to generate these DSFs, but ultimately they do crop up and they drive spontaneous activity and would then presumably be a generalizable target that could be addressed.
Okay, yeah, that's something that we at AnaBios can work on. We do get DRG samples from donors that had diabetic peripheral neuropathy. So, we're getting good questions from the audience still. Another one is, what immunohistochemistry or immunofluorescent markers could one use to indicate DRG neurons that have been exposed to a drug that causes CIPN?
Boy, that would be a great. We have been looking for just such a marker. Is there a way? Is there an activity-dependent marker that we could toss in onto these ganglia? If they come up with that, that would be awesome. Because right now, just given the way we've been going about sampling the cells, you know, we can patch, say, a dozen cells or so per patient before you start oversampling on a given patient. We know that that's adequate in order to detect spontaneous activity if it's present, but I don't know really how many of the neurons in a given culture sample are active. So if there was a way we could just toss a dye in there and all the ones that were spontaneously active would take it up, we could probably get a much better idea of exactly what is the overall frequency of spontaneous activity in the culture as a whole.
All right. Another question, how do you think PAC induces inflammation? Is this systemic?
So Taxol interacts with toll-like receptor 4. The platin compounds also do, and there's a lot of in vitro data that backs that up, both in immune cells and in non-immune cells, including neurons.
Okay. And a related question, are there specific transcripts or pathways that indicate response to a particular chemotherapy?
Are there specific transcripts that indicate? I'm not sure I follow that question entirely. Is that in the neurons, or I'm not sure I understand that question. So perhaps that attendee could reframe that question. Okay.
And are there TLR4 inhibitors as pharmacological tools that could be examined?
Oh yes, there are. There are a number of those. We use LPSRS, but there are other TLR4 small molecule inhibitors out there as well that have been developed for sepsis. The names are not, they're bouncing off my cortex right now, but you can find those. They didn't advance in the sepsis world, and they're just kind of sitting out there. So I don't know what the status of further development of that might be.
Okay, very good. Well, looks like there are no further questions. Patrick, again, thank you very much for your time. We appreciate you sharing this presentation.